Today we're tackling lipoprotein, or LPA.
Okay, yeah. Great overview from the American Journal of Preventive Cardiology. But if you have high LPA, which is like surprisingly common, it could still be a major hidden risk factor for heart disease.
And it's mostly inherited, isn't it?
That's the key thing, largely genetic. So it's a fundamental part of your sort of personal risk profile.
We're planning to break down why it's so important, look at the genetic side, how it connects to different heart and vessel
The
conditions.
specific ways it actually causes trouble.
Right, the mechanisms and why screening is becoming a bigger topic, plus what we can do now, while also keeping an eye on some very promising treatments coming down the pipeline.
Yeah, the treatment side is getting exciting.
But here's something that really stood out to me. About 1 in 5 people globally have high LPA.
1 in 5.
The evidence strongly points to it directly contributing to plaque buildup, even if your LDL is well managed with statins or lifestyle.
Which really highlights that LPA could be driving a lot of that residual risk we sometimes see, when people still have events despite good LDL control.
Right.
Now, the LPA particle itself is, well, it's kind of fascinating. It's basically an LDL particle.
The bad cholesterol particle.
Yeah, but with this extra protein stuck onto it called apolipoprotein, or ApoA. And the review notes that the amount of this apopene you make is largely down to your genes. And it looks structurally quite similar to another protein involved in blood clotting, plasminogen.
Which we'll probably come back to later.
We will.
But connecting this back to the genetics, you said it's huge, like over 90% determined by one gene, the LPA gene.
Which technically makes high LPA the most common inherited lipid disorder.
More common than familial hypercholesterolemia, even.
Way more common than heterozygous FH, yes. And the LPA gene itself, the review points out, is considered one of the strongest single genetic risk factors for coronary artery disease.
Stronger even than genes related to LDL receptors or PCSK9 sometimes.
In some contexts, yes, it's a potent risk factor.
And this LPA gene, it's not the same in everyone, right? You mentioned variability. I read about something called Kringle-Hyvie type 2 repeats.
KIV2.
Exactly. The gene has these sections, the KIV2 repeats, and the number of repeats can vary a lot between people, from just a few to over 40.
And this dictates the size of the ApoA protein that gets made. Generally, fewer repeats mean a smaller ApoA protein, and that tends to lead to higher LPA levels in the blood.
And more repeats mean a larger protein and lower levels.
Usually, yeah.
Yeah.
These differences in the KIV2 region explain a huge chunk of why LPA levels vary so widely in the population.
So it's not just if you have the gene, but which version, essentially.
Precisely. Which really underlines the importance of family history. If someone has high LPA, screening their close relatives makes a lot of sense.
Yeah, cascade screening. And this feels like it ties into personalized medicine too, doesn't it?
Absolutely. Understanding these gene variations, maybe combined with ancestry, could potentially help us fine-tune risk assessment down the line. Maybe even tailor treatments eventually.
The review mentioned researchers are actively trying to figure out how specific LPA gene variants link to how the disease shows up and the overall CVD risk.
It's a really active area.
Okay, so we've established this high LPA is largely genetic. Now, how does that actually translate into, heart attacks and strokes and other problems?
Well, the sources are pretty clear on the associations. High LPA is strongly linked with coronary artery disease, ischemic stroke, and peripheral artery disease.
The big ones.
Definitely. But the connection that seems particularly strong, maybe the strongest, is with calcific aortic valve stenosis, and what's striking is that the LPA gene is actually the only single gene risk factor identified specifically for CAVS so far. And supporting that causal link, studies show people who are genetically wired for lower LPA levels have a reduced risk, not just of AVS, but also CAD, PAD, and stroke.
Which suggests lowering it with drugs could potentially offer similar benefits, right? Although these are lifelong genetic effects.
That's the hope, definitely. That's what the big trials are testing.
And it's not just those sort of classic atherosclerotic diseases. There's talk about heart failure and atrial fibrillation, too.
Yeah, there's growing evidence there, too. The link with heart failure might partly be because high LPA increases the risk of CAD and CAVS, which can lead to heart failure.
Sure, that makes sense.
But there might be other ways LPA contributes, maybe affecting artery stiffness, things like that.
And atrial fibrillation, that's interesting.
Yeah, some recent findings suggest LPA might directly contribute to AFib, independent of its other effects. Still needs more research, but it's definitely on the radar.
Okay, so we know high LPA is a problem linked to all these conditions, but how?
The review digs into this, and it basically highlights 3 main ways. It's pro-atherogenic, pro-inflammatory, and prothrombotic.
So plaque building, inflammation, and clotting. A triple threat.
It seemed to attack our arteries on multiple fronts.
So the proatherogenic part, it helps build plaque.
Yes. Evidence shows both parts of the LPA particle, the LDL-like bit,
Yeah.
and that unique ApoA bit can get trapped and build up in the artery walls. It seems to be there at all stages of atherosclerosis, and you find higher amounts in more advanced plaques, even ones that have ruptured. And more recent work has linked high LPA specifically to plaque features that make them more, vulnerable, more likely to cause a sudden heart attack or stroke.
And the inflammation piece.
Also seems really important. Studies show more inflammation in the artery walls of people with high LPA. It might make it easier for immune cells, like monocytes, to get into the wall and stir things up.
And it mentioned oxidized phospholipids earlier. OXPLs.
Right. This is fascinating. It looks like APA, that unique part of LPA, is a major carrier for these OXPLs, which are known to be very pro-inflammatory.
Okay.
And the amount of these OXPLs carried on LPA has also been linked to the calcification process, not just in artery plaque, but especially in that aortic valve stenosis, CAVS.
So LPA might be helping to kickstart the calcium buildup on the valve.
It seems to play a role in those early stages, yeah, which is a key driver of CAVS getting worse.
Okay, and the third part, prothrombotic, making blood clot more easily.
Yes. Remember how ApoB looks similar to plasminogen?
The body's natural clot buster.
Exactly. So the long-standing idea is that high LPA might interfere with that process. ApoA could sort of compete with plasminogen, maybe gumming up the works for clot breakdown.
Like a faulty key trying to fit the same lock.
Kinda, yeah. Potentially slowing down the breakdown of fibrin, which is the mesh that holds clots together.
Is the evidence strong for that?
Well, the exact role is still being hammered out,
Right.
but there's evidence suggesting ApoB can compete with plasminogen. Plus, some studies suggest LPA might also directly promote clot formation by activating platelets or messing with proteins that normally prevent clotting.
So it could be working through multiple clotting pathways.
It seems complex, definitely multifaceted.
Okay, so all this paints a pretty clear picture. High LPA is a serious, multi-pronged risk factor.
No doubt about it.
So the big question then becomes, what should we be doing? What should doctors be doing? The review strongly recommends measuring it, right?
Absolutely. Many clinical guidelines and expert groups now suggest measuring LPA levels.
But who should get tested? Is it everyone?
Well, that's evolving. Some guidelines focus on people with a history, personal or family, of early heart disease, or those already known to be at moderate or high risk.
Okay.
But others, like the European Atherosclerosis Society and some recent U.S. recommendations too, are proposing we consider measuring LPA at least once in every adult's lifetime.
At least once. That feels like a potentially big shift, especially for primary prevention.
It does, and it's important for understanding someone's risk, even if their standard cholesterol panel looks fine.
Because a standard lipid panel doesn't include LPA, right?
Correct. It's a separate test. You could have perfectly normal LDL and triglycerides, but still have sky-high LPA.
And the sources mention studies, like the Brunex study, showing that adding LPA testing really helped predict risk better.
Yeah, it's significantly improved risk prediction and helped reclassify people, especially those who initially seemed to be at intermediate risk based on traditional factors. Knowing the LPA pushed some into a higher risk category where more intensive prevention might be warranted.
So knowing your number can really refine that overall picture and potentially trigger more aggressive management of the things we can change, like blood pressure, smoking, diet, LDL.
Precisely. The review even mentions ways to incorporate the LPA level into calculating someone's 10-year risk score.
But here's a disconnect, maybe. The evidence and recommendations are growing, but is it actually being tested much?
That seems to be a major gap. The review cited data from a huge U.S. healthcare database in 2022 showing that only a tiny fraction, like a really small percentage of people, had even one LPA measurement recorded.
Wow. That is striking. So why the gap?
Well, the review touches on a few potential reasons, maybe a perception that there weren't specific treatments, which is changing now.
Right, the what do I do with the result issue.
Exactly. Also, setting a single universal cutoff level is tricky because baseline levels can vary quite a bit across different racial and ethnic groups. So the thinking seems to be shifting towards viewing LPA risk more as a spectrum, a continuum, rather than a simple high or low switch.
That makes sense. Like, the higher it is, the higher the risk generally.
Pretty much. The European Atherosclerosis Society and the U.S. National Lipid Association suggest thinking about it in ranges. Levels below 75 nanomoles per liter are generally seen as desirable,
Okay.
while levels above 125 nanomoles per liter, which is roughly 50 milligrams per deciliter, are considered very high risk. And there's that gray area in between.
So doctors can interpret the level in the context of everything else going on with the patient.
Exactly, their overall risk profile.
Okay, so while we're waiting for those specific LPA-lowering drugs, what can people do right now if they find out their level is high?
Yeah, the review offers some practical advice. It emphasizes a risk-based approach, meaning use that LPA level to intensify efforts on everything else. Use risk calculators that include LPA. Maybe consider imaging like a coronary calcium scan.
To see if there's already plaque buildup.
Right. Look at inflammatory markers too.
Yeah.
And lifestyle is key things consistent with the American Heart Association's Life's Essential 8. Healthy diet, exercise, not smoking, all that becomes even more important.
Good advice for everyone, but maybe extra critical here.
Exactly.
Now, what about current medications? Statins are the go-to for LDL, but they don't really lower LPA, do they?
No, they don't significantly lower it, and some studies suggest they might even slightly increase it, though the clinical impact of that is debated. Niacin was tried, but the benefits didn't seem to outweigh the side effects and risks in major trials.
Okay. But what about the PCSK9 inhibitors, the injectable cholesterol drug?
Oh, now that's interesting. While they're not specifically approved for LPA lowering, secondary analyses from their big outcome trials showed they do lower LPA, maybe by around 20–30%.
Okay, a modest reduction.
Modest, but potentially meaningful. It looked like the patients who had greater LPA lowering also had greater clinical benefit in those trials.
Interesting. And then there's apheresis.
Lipoprotein apheresis, yeah. It's like dialysis for lipids. It physically removes LDL and LPA from the blood.
But that's pretty intensive, right?
Very intensive. It's really only an option for a very select group, patients with familial hypercholesterolemia, FH, who are very high risk and also have very high LPA that isn't controlled otherwise, not widely available or used.
Got it. The review also mentioned low-dose aspirin.
Yeah, there's some data, mainly from subgroup analyses of primary prevention trials, suggesting aspirin might be particularly beneficial for people with high LPA, but it's not definitive. More research is needed there, especially weighing bleeding risks.
Okay. And given the genetics, if you find high LPA, definitely consider testing family members.
Absolutely. Cascade screening makes a lot of sense.
All right. But the really exciting part, maybe, is what's coming next, the specific LPA-lowering drugs.
That's where the real buzz is. There are several therapies in late-stage phase 3 trials right now,
Like what?
mostly targeting the messenger RNA, the instructions from the LPA gene. There are antisense oligonucleotides, or ASOs, like pelacarsen, and small interfering RNAs, SIRNAs, like olpasiran, zerlasiran, and lipodisiran.
Okay, fancy names, but they basically stop the apoprotein from being made.
That's the idea, yeah. And the results from earlier trials have been, frankly, quite dramatic, showing LPA reductions of like 80%, 90%, even higher in some cases.
Wow, that's a huge drop.
Massive. There's also an oral drug being tested, a small molecule called muvalaplin, which works differently by stopping OPT from linking up with the LDL particle.
An oral option would be great, too.
It would. But the crucial thing now is waiting for the results from the big cardiovascular outcome trials for these drugs.
To see if lowering LPA that much actually translates into fewer heart attacks, strokes, and deaths.
Exactly. That's the billion-dollar question. Those results are eagerly awaited.
It really feels like a rapidly advancing field. The potential to finally have targeted therapies for such a common and potent risk factor is, well, it's significant.
It really is. And the review rightly concludes that, we need to make a conscious effort now to screen for high LPA, to better understand individual risk, use the strategies we currently have to mitigate that risk.
While we wait for these potentially game-changing new treatments.
Precisely.
Okay, so let's try and summarize the key takeaways for everyone listening.
Sounds good. So first off, high LPA seems to be a direct cause of atherosclerotic cardiovascular disease, and it acts independently of your LDL cholesterol.
Right. It's its own problem.
Second, it's actually the most common inherited lipid disorder we know of, and a very strong genetic risk factor for ASCVD.
Mostly determined by that LPA gene, with those KIV2 repeats playing a big role in your level.
Yep. Third, high LPA is strongly linked to coronary artery disease, ischemic stroke, peripheral artery disease, and especially that calcific aortic valve stenosis, CAVS. Links to heart failure and AFib are also being explored.
And it does its damage through sort of three main ways: promoting plaque buildup, causing inflammation partly via those oxidized phospholipids.
And potentially interfering with blood clot breakdown or promoting clot formation.
Okay. And what should people do?
Current guidelines increasingly recommend measuring LPA at least once in adulthood for a full risk picture.
Knowing your level can help refine your risk category, especially if you're borderline, and might push for more intensive management of other risk factors.
Right. Think of the risk as a spectrum, but levels over 125 nanomoles per liter or 50 milligrams per deciliter are particularly concerning.
And while we don't have specific LPA-lowering drugs approved yet, current management focuses on optimizing everything else, lifestyle, blood pressure, LDL, etc.
Although those anti-PCSK9 antibodies do lower LPA somewhat, and apheresis is an option for very niche, high-risk FH patients.
Don't forget cascade screening for families.
Crucial. And finally, those new targeted therapies, pelacarsen, olpasiran, and others hold huge promise and are in final testing stages.
It's a lot to take in, but really important information.
Absolutely.
So, to leave you with something to think about, given everything we now understand about LPA, how common it is, how potent a risk factor it is, and with these targeted therapies potentially just around the corner, how might universal LPA screening truly reshape the way we approach preventing and treating cardiovascular disease in the coming years?
That really opens up big questions, doesn't it, about cost effectiveness, how we'd actually implement that kind of widespread screening.
And what it means for the future of personalized medicine and cardiology. Lots to consider.